Hello, and welcome to the We Talk Health podcast, the official podcast of West Tennessee Healthcare. I'm your host, Kara Mobley, and on today's episode, we are discussing Hospice of West Tennessee. This episode combines two different interviews I did. The first interview is going to be with Dr. Stephanie Anderson, the Hospice Medical Director, and the second interview in this podcast is going to be with two Hospice LPN nurses, Brittany King and Kayla Shaw. And now, on to the show. Here with me is my guest, Dr. Stephanie Anderson. She is the Hospice Medical Director here. Welcome to the show.
Thank you so much. Thanks for having me.
So this is your first time on the show. What I want to kind of start with is to just let people know who you are and how long you've been here and what is your role here with us.
I've been here for approximately 12 years.
Oh, wow.
I did residency here, worked in the emergency room and still work in the emergency room. Started hospice in addition to the emergency room in February and took over as the medical director in July.
Okay, great. Now, as far as hospice, I know we've talked within the system here that not a lot of employees are aware of this service, and we definitely want to get this message out to the community of West Tennessee because this is such an important service to provide. And my first question is, what is hospice?
So hospice is an integrative experience with a nurse-driven team approach. Our team consists of nurses, CNAs, social workers, chaplains, volunteers, a director, patient care coordinators, a secretary, marketing advisor, billing coordinator, nurse practitioners, and physicians. So we have a whole team, and it's a philosophy, not a destination. It addresses a patient's clinical, emotional, and spiritual needs while honoring their goals and wishes for end of life, allowing them to live out their remaining days, weeks, months, however much time they have left with dignity, respect, and autonomy.
Right. Now, I'm not very familiar with hospice myself, so this is also educational for me. All the people you just listed, I would have never known that all those people were involved. So that's great to understand that it's not a small thing. It's
by any means.
Right. So that's, you kind of told what all is involved with hospice if people aren't quite aware of what hospice is not.
So there's a lot of misconceptions about hospice. First of all, hospice is not a death sentence. We're all going to die one day just as sure as we were born one day. So getting that out the way up front, just because you go into hospice doesn't mean, it's all over. Yes, we deal with a life expectancy of 6 months or less if you have a terminal illness. And we tend to help manage symptoms during that time. And hospice is not pain management. We manage pain in hospice, but that is not our primary only goal. Of course, we do it well, but it's not a pain management clinic. And some people may kind of get that confused as well. And it's definitely not giving up by any means. It's just accepting that you have a terminal illness or have something that's not going to be cured, or I'm tired and I don't want to do this anymore.
Right.
And I just want to live my last days as best as I can without symptoms. So it's just accepting that something has changed beyond control and kind of taking the attitude of I'm ready for whatever's next as much as I can be.
Right.
And it's definitely not euthanasia. It's not physician-assisted suicide by any means.
Right.
We neither hasten or postpone death.
Now, you made an interesting point during that with it's not pain management, but it involves pain management. I guess if people are maybe confused on when they would be eligible for it, so maybe tell us who would be eligible for hospice.
Anyone who has a terminal illness, and that just means a prognosis of less than or equal to 6 months. If your loved one has a declining functional status, meaning dependent in 3 of 6 of what we call the instrumental activities of daily living, which include bathing, hygiene, dressing, grooming, mobility, toileting, and bowel and bladder control. If any of those are lacking in 3 of those 6 areas, it may be something to consider as well, because that means there's a decline in your functional status and physical status. Any observed and documented deterioration in overall clinical conditions in the past few months, and clinical conditions can be varied. I mean, it's far and wide. It doesn't have to be one specific thing, although we have specific diagnoses as well. If you've had more than 3 hospitalizations or ED visits in the last year, it may be something to consider as well. Any decrease in tolerance to physical activity, or any decrease in your cognitive ability, or if you notice that in your loved one.
Right. And I can imagine if it is you that's going through that, or if you're the loved one of someone going through that it can be overwhelming to face having to make this decision. So what would you say are the goals of hospice?
Well, our goals, I think, are pretty simple, because this experience we call death occurs when the body completes its natural process of shutting down, and the spirit completes its process of reconciling and finishing its course. So our care is directed toward assisting each patient to achieve the level of self-care and independence, to live fully and to die with dignity, while supporting their families.
Exactly right. Now, a lot of times when people mention hospice, the word palliative care is also mentioned within that same framework, and I'm not altogether sure myself. So could you tell us what the difference is between hospice and palliative care?
So hospice care, as we talked about before, is terminal diagnosis. Prognosis is less than or equal to 6 months. So it's comfort care without a curative intent, meaning we're not trying to fix it or make it better. We're just trying to live our remaining days the best way we can. The patient no longer has those options to receive treatment or a cure for what their condition is. Or they've chosen not to pursue treatment because the side effects outweigh the benefits for them. Palliative care allows for patients diagnosed with an advanced illness to be cared for anytime throughout their illness. It doesn't matter if it's beginning, middle, or ending.
And I guess if someone, like you mentioned just then, if someone, they get a diagnosis, there are treatment plans, and they decide, I don't want to go through that because of all the side effects along with the treatment, what would you say for the medical team? I feel like maybe sometimes people would think that a doctor's not going to let them make that choice, that potentially the healthcare system would say, no, we want to do this for you, even though that's not your choice. I kind of maybe want to say that, or let people know that it is their choice at that particular point in time, I would guess.
Well, any medical care is your choice.
Right.
I mean, we advise, we knowledge share, but ultimately you're the ones, we are. If it's you have to make your decision based upon, we call it an informed decision.
Right.
So we try to give you all the information of whatever the condition is, what the medications, side effects, and we try to have that conversation in an honest way, because for some people, their goals are different.
Right.
And every person is different, so you kind of have to individualize it. And yes, I'll be honest with you, it's hard for some of us, especially if you're medical, because
right.
I work in the emergency room.
Right.
We fix everything, or we try
to. Right. That's in your nature, like that.
Yes.
That type of job.
So we're aggressive by nature because we're trying to fix it and make it better. And what can we do to make you all better and to live longer? So it's kind of a different thought process. Mm-hmm. And we have a lot of people who are really good at having those conversations. We have a lot of people who are really not good at having those conversations. Right. And it's okay both ways because it's a comfortability thing.
Right. And it seems like potentially that knowledge within the community, the general community, they don't know how much of the decision lies with them. Like you as the patient have a lot more say in your treatment and your plan.
Yes, by all means.
And we definitely want to let people know that they have that power. It is ultimately up to them for the treatment.
I'm a firm believer. Advocate for yourself.
Right, exactly.
Advocate for your loved ones. Ask questions. There's a lot of information out there.
Right.
And you have to ultimately consider what's the best plan for you. And I get it. For a lot of us, if you don't know, you're going to do pretty much everything that you're being told to do because it's in your best interest according to evidence-based medicine. And that's okay too. But
right. And I've even got family members, and that's happened with me before too. When you go to the doctor and someone's talking to you, sometimes it's so overwhelming to get all that information that if you have someone, that you have a loved one, you have a caregiver or someone that can come with you, would be best to have another person in the room. That way you guys can make an informed decision together. So it's not just the burden of information is on you as the patient.
That's true.
So what would be some conditions which would qualify someone for hospice?
As I said before, it can be so many different things, but some specific ones, of course, is everyone always thinks about cancer. Mm-hmm. That's a pretty big one that can qualify you for it. If you're no longer looking for radiation, chemo, or any treatments to prolong life. Heart disease, dementia are some of the other ones. Aspiration pneumonia, pyelonephritis, which is just a big long word that means angry urinary tract infection that goes back to the kidneys. Sepsis is a pretty common one people hear. If people have multiple pressure ulcers and they're not eating as much as they have 30, 40-pound weight loss in the last 3 to 4 months. Recurrent fevers, and of course a host of neurological disease, Parkinson's, myasthenia gravis, ALS, as most people know as Lou Gehrig's, multiple sclerosis, muscular dystrophy, kidney disease, end-stage COPD, liver disease, strokes, comas, and we can go on and on and on. So it's not one specific per se group. Some things are black and white, but for the most part, if it's a terminal diagnosis and the prognosis is less than 6 months, it's definitely a conversation worth having.
Okay. So within the West Tennessee healthcare community, we've got hospice here. They don't have to go to Memphis. They don't have to go to Nashville. This is a service that we provide right here in West Tennessee. If someone's listening to this podcast and is wondering, if they qualify or if someone they know would qualify, how would a patient be referred to hospice?
So the great thing about it is you can be referred by your primary care provider or PCP, as most people know. And, of course, with the hospital here, we get a lot of referrals from the hospitals for people who are inpatient or oncology or any specialist if they think continuing trying to cure is not the goal of therapy at that moment. But patients can actually refer themselves.
Oh, okay.
So you can self-refer. Family members can refer, loved ones. So it's pretty open as to who can refer. And you mentioned that you don't have to go to Memphis, you don't have to go to Nashville. Yes, we have hospice here, and we all have our geographical areas that we take care of. So the good thing about it is if you're in a hospice program, it doesn't mean you're tied to the area. If you want to go on vacation or you want to take a trip, you can. And we just contract with a different agency in that area. So you're taken care of while you're there if something comes up emergently, so to speak. And the thing about referrals, too, that I think is worth mentioning, just because everyone has a condition that may benefit from hospice, it doesn't mean they're ready for hospice.
Okay.
It's a mental and physical process. It's an emotional process. And for anyone, because I know people, prime example, one of my nephew's mother, she was 40, she had breast cancer. Metastasis everywhere. She was 40, a single mother of 3 kids. She was not mentally ready for hospice. They had the conversation with her. She died within 6 months, but she wasn't mentally ready. So you have to be ready mentally, physically, emotionally, and spiritually.
Right. And you don't want to push that on someone. I wouldn't.
Definitely not.
You would want to have that conversation, but ultimately let that person decide if this is something they want to pursue.
That's true. And it's just like anything else. You're informing of options. What's available to you.
And within this program here, is that something you would maybe do like a consultation with someone through hospice to kind of talk through it and let that person decide? Is that how it would go? What the process would be?
Yes, we have a great team. And we also have the palliative care team in the hospital as well, who do a lot of consultations for us, or we get a lot of the consultations through them, so they have a lot of those conversations. And then we have our wonderful admission nurses. So if anybody feels that they are a candidate for hospice, we will have a conversation with you, and we're open to that.
Okay, great. So that's good to know, where you can reach out just to get some more information to see if this would be something you're interested in, or somebody else. Do you have the number for?
I do.
Okay. And I'll put this in the show notes as well.
It is 731-664-4220.
Okay, great. And I can also share the web page as well that'll have more information on our hospice
That would
program.
be great. We have on-call nurses. That's the good thing about hospice as well. You have care 24/7. Once the office closed, there's on-call nurses, so you have 24/7 access to care.
Right. And I know the Hope and Healing Foundation that's recently new here in West Tennessee, that is one of their goals, is to have a hospice home here in West Tennessee.
Yes.
So that's something that we're working towards.
Yes, we're pretty excited about that and hope it will come to fruition really soon, because it definitely would be a big benefit to the community. And a big benefit to patients and their families. during this special time.
Right. Do you have any final thoughts you want to share with us?
Well, I would just encourage everyone. We don't always know what's going to happen in life, but the great thing is there are so many resources out there, and this is just one of many. In the beginning of life, we have a specialized team who provides guidance, direction, and interventions to ensure a smooth birthing process during the transition into life outside of the womb. Well, we're the specialized team who desires to help navigate the process when the heart is preparing to be for only one last time. It's our goal to facilitate care for you and your loved ones that allow for a peaceful and desired resolution of life while supporting your family and friends before, during, and after the moments surrounding that goodbye, while encouraging the survival of the heartbreak of the loss, while celebrating and honoring your loved one's life and legacy. As Helen Keller so eloquently stated, what we once enjoyed and deeply loved, we can never lose. For all that we love deeply becomes part of us.
Exactly. That's a very beautiful statement. And I'm so glad that we had this podcast because, like you said, you have so many people that are there for you at the beginning and all throughout your life. This is just another part of that you don't have to go it alone towards the end, as you said. Well, thank you so much for coming in and joining us and telling us all about this is such an important thing to get out to the community. We want everyone here in West Tennessee to know about this, that this is an option for them.
Thank you for having me. It's been an absolute pleasure. And we're glad that you're helping spread the word.
Yes, thank you so much. Okay, we've got 2 hospice LPN nurses with us. It's Brittany King and Kayla Shaw. Thank you guys so much for coming on today.
Thank you for having us.
So you guys are new to the show, so I wanted to get to know you guys a little bit better. We can start with you, Brittany. How long have you been a nurse?
It's 3 years, almost 4, since 2021. Yeah, that's when I graduated. So it's been 3.
So did you start
me in math?
Did you start in another department, or did you go straight into hospice?
I started in long-term care because when I graduated, I knew I wanted to do hospice, but they said LPNs, they don't hire them in hospice. I talked to a lot of different agencies and they were not hiring LPNs in hospice. So I did long-term care, which I loved, but it's a lot of work, long hours. And eventually that actually led into me becoming a hospice nurse.
Great. Kayla, how about you? How long have you been a nurse?
I've been a nurse for 5 years.
Great.
And I started out in long-term care. Then I started doing some travel work with the prisons and jails. Okay. And then been with hospice since about August. So I'm the newbie.
Yeah, newbie.
I've been there about 2-3 months now, and I love it.
Great. So this question is for both of you. You both talked about you started in long-term care. How did you guys get involved with the hospice program?
Well, for me, it was while I was in long-term care, I was taking care of a hospice patient. Well, there is one particular patient that was with a West Tennessee patient. Mm-hmm. And I kept calling because he was just not comfortable. And, in long-term care, most nurses that don't understand hospice are kind of against giving certain medications. So I gave the on-call nurse my personal number because I wanted to make sure that med changes were made, and if I needed to go back in to make sure he was comfortable, like I was going to do that. And she was like, you're a really good nurse. Have you ever thought about hospice? And I was like, well, that's all I've ever wanted to do. That's why I went to school, was to be a hospice nurse. And she's like, well, we're hiring LPNs. And so I became the first LPN in 20 years to work for them and the first LPN case manager that they've ever had.
Wow. And that was when? When did they open that up to LPNs?
Let's see. It was 2022, I believe.
Okay.
Look, me and numbers.
So yeah, just within the last year. So.
Yeah, it's been a year and a half since I've been there. I started in July, so it's going on a year and a half. Mm-hmm. And so June. I started in June. Sorry.
Okay. And Kayla, I wanted to open that up to you. How did you get involved in hospice? What kind of led you to that?
Honestly, I kind of just slipped into hospice in a way. I had just finished a travel contract, and I was praying. I was like, God, I want to help people. Mm-hmm. I really want to make a difference in people's lives and things like that. And out of nowhere one day, my old boss, who's also a case manager there, she gave me a call. She was like, hey, are you like working anywhere, or are you interested in a new job or anything like that? I was like, sure. So I reached out to the director at the time, and she said that she loved me, loved my personality, and she thought I would be a great fit for the team. And I was like, well, I guess that was, a
what was
sign
meant
from,
to be.
Yes, because she was like, we prayed this morning in our meeting and just prayed for him to send us people who wanted the job and wanted to work. So
I mean, she fits right in. I mean, she's very knowledgeable and very compassionate, and
like, I never thought I would do it, but I have had like personal experiences with hospice in my family.
Oh, okay.
And that's what made me think, okay, this is something that I would try to do, something I might actually like. And then now I love it.
Great. Now, Brittany, I know you mentioned that you're an LPN and they just opened that up to LPNs. Tell me a little bit more about that. What it's like to be a licensed practical nurse in the hospice field.
well,
I guess, what is it different from being like an RN?
yeah, there's not a whole lot of difference besides we can't pronounce and we can't do an admission because the initial assessment has to be done by an RN. We can't flush ports.
Okay.
But I mean, other than that, I mean, there's really nothing we don't do. I've even been on death visits. When I was a case manager, I've done postmortem care. I've trained RNs in how to, pronounce
the practical side.
Yeah.
And chart.
Yeah. I mean, so it's just really all about how long you've been to school. But, I think sometimes just personal experience helps.
Yeah, that's a big thing. Well, and so it's part of a team effort. Like,
absolutely.
You're working with RNs are working with LPNs in this field. It's kind of like you're not alone in what you're doing to help these
in
people.
Your team, we have an RN, and then we have a chaplain, and then we have a social worker
and hospice aide.
And then we have us LPN floaters, which is Kayla, myself, and Christy, which is the other LPN. And we just go where needed to help relieve the load. And we all have to communicate and be on the same page. So, effectively, we're giving the best care and making sure that the team, every patient is seen and taken care of.
Mm-hmm. Right. So as an LPN in hospice, I know hospice obviously is very different from other nursing professions, like in a hospital setting or a clinic setting. What would you say is a day in the life for your position within hospice? Is every day the same, or is every day different?
It's actually it can get wild.
Yeah.
Some days it is a routine visit. You go, you get their vitals, you assess them head to toe, you refill medications. They don't really need much from you, and you go on about your next visit. Mm-hmm. But then there's those other days where they can't urinate, so you've got to get in that catheter, and you have to.
It's really hands-on.
Yes, the family doesn't understand. They thought it was just a part of the way they're supposed to go. So they're like abnormally breathing. And so you have to go and you have to do a lot of education on meds and change meds and call doctors. And so you have to get creative.
Right. And this is also not a stationary position either. And you even said floater, which means, I guess a hospice can take place in the home, in a hospital, in a nursing home. So you guys are traveling daily, or how does that work?
Yes,
with
every day.
Schedules,
and we go where they are.
Yeah. So what advice would you give to any new nurses or nurses who are in another field who have kind of maybe been thinking, is hospice something I want to transition into? Kind of what advice would you give of what it's like?
I would say make sure you're mentally stable for the position, because besides like regular nursing care, like vital signs, things like that, we are a big impact on the families. They're grieving. How can we cope with this and things like that? So it takes a big emotional toll on you, especially being a hospice nurse.
Right. And that brings me pretty well into the next question is, once you're in hospice, obviously you're dealing with end of life, but what is it like for you being surrounded by that? How are you supported outside of your job for your mental health, like you said? Or what do you do to kind of help yourself with your mental health? Dealing with that.
For me, it's having a spiritual relationship with, God, reading my Bible, trying to stay encouraged, calling them, because they understand how I feel. because they know exactly what I'm talking about. If I call anyone else, they're like, they just don't completely understand. Like, you chose this, like you want, but they don't understand, like, we love this, but it also can be very draining. So for me, it is sometimes just taking a few days to just, I'm not going to do anything today. I'm just going to kind of relax, and I pray a lot. And that just really helps
we pray a lot as a team in the office.
Oh, that's great.
We probably pray, some days we pray 2-3 times a day in the office when we're together. And that's one thing I do love. And at home, I mean, I have my family, and I just try to look at it like I could be in our patient's shoes, like, or my mom could be in our patient's shoes. So I try to enjoy, like, the moments with my family as much as I can. Like, yes, it's emotionally draining, and some days I just want to go home and cry, or just go home and, like, bury myself under my covers. But then I think about our days are numbered, so you have to get up, you have to go out and get fresh air and
to piggyback off what she said, it can be very humbling to be in this position, because I think every single one of us take life for granted.
Yes.
You know, we do not realize that more and more there's people our age that are on hospice. You know, we've had just this past year someone as young as 22. I have one that's 36 right now. You know, they're in their 40s, 50s, and everybody thinks, you know, they have forever, you know, or I got 30 more years, but you don't know. So it makes you, like, really forgive easier, love harder, and just
it kind of puts things in perspective.
Yes, and it tells you, it makes you want to live, like really live and enjoy.
And kind of, Kayla, what you said, having a support system at home is very important to have. You know, if you feel like maybe you don't have that, this might not, you know, it might be a much more difficult if you don't have a strong support system to go home to. And especially, like, with therapy, you know, that's always a thing that we're trying to encourage people to do more nowadays, where it's, you know, this taking away the stigma of talking to a licensed therapist about, you know, what you're feeling and how you're handling things.
Yeah, I don't even know that a therapist is ready for me.
But again, like you said, that was another thing, like you said, is you're able to talk to the community of people within your department, other hospice nurses, other hospice people with, you know, even with different roles, you know, within the hospice community, having that support system as well.
Yeah.
Because they also can understand what you're going through.
Yeah. You know, when my dad passed, my son was 7. And that's the first time I had to deal with hospice. I had no clue what it was about, what to do.
The process was.
And so my hospice nurse was just so sweet. She was just precious, and she was patient, and I just saw, like, the care, and it was the little things that she did, but I was like, I want to be that.
I want
to make that difference. I want to. And I've done that, and that is just, like, the best feeling. But, you know, when my dad passed, my son was there, and he just went outside, and he was like, you see that bright star right there? That's people. He just went up there. And I was like, you know, that I'm just so glad that he got to be a part of that, even at 7. Like, of course, he was so close to my dad, but he was able to be a part of it, you know. And then when my mom passed, he wasn't a part of that process, and so he didn't understand
what was going on,
what happened, like why she's just all of a sudden gone. So it was harder for him with my mom passing because it happened so quickly versus him actually getting to be there during the process of my dad getting to pass.
So I would say that leads into, what is the hardest part of this job?
I would say I get really attached to certain patients, and sometimes it could be just a few days that I've known them. It could be the first time that I've met them. You know, you have, like, those certain things about people that remind you of certain people that have passed. And it's like you immediately just have, like, this connection with them, and you get really close to these families. And it's like, once that patient passes, you're like, you don't get to see him anymore.
Like,
you know,
I probably would never see this family again.
Yeah, like, sometimes you have those that check in, but then, like, you're like, oh, I can't believe I really don't get to see that person again. Or so it's almost like we're constantly losing people.
Oh, right, yeah. I think even myself, that that's not something that people think about from the other side, is that, the nurses had that person in their life for, whatever extended period of time that was, and then they suddenly...
They think we just move on. Like,
right.
On to the
And
next,
not,
and it's like, no.
We still think about your family member, and that's hard.
And so that kind of brings me into, do you guys have any memories of patients that you hold on to? I know I spoke to Dr. Anderson that the nurses will have, you guys have meetings every, what'd she say, Thursday. To talk about your patients. And that's not something that a lot of people know about. So kind of give me an idea of what that's like.
Well, we all come together, from the social workers to the nurses to the LPNs and the doctors, volunteer doctors. And we come together and we talk about the patients by last name, and we'll say what they're in hospice for, where they're at in their decline, or if they're getting better, and maybe we need to look at discharging them and maybe getting them back into a primary care physician that can reassess and maybe get some other solutions going besides hospice. And we look at treatments, we'll speak with the nurse practitioners and kind of go, if we need to change anything, we'll all discuss that and just kind of get everybody's input on each patient.
Yeah, I think people think once people get on hospice, that's it. There's no coming back. There's so many people we've had for years. Right. We've had a few I know one lady I have for 3 years.
Oh, wow.
And, I mean, of course, I haven't been there for 3 years, but she had been on service for 3 years. And then we've had some that we've had to discharge because they've gotten better. So it's not the end just because someone gets on hospice. You can be on there for a while.
Right.
We can clinically in a book write down the dying process and how it traditionally would go. But there's been so many times that you see that and people will bounce back, and that's because it just was not their time.
Right. Or sometimes you don't see it and then they end up leaving, and they never have that major decline where they stop eating, stop drinking and stuff. They could be talking one day and the next thing you know they're gone. Yeah. And that's a hard part.
You asked a favorite memory of patients. So saying that, I had a lady, and she used to color me pictures.
Oh.
Every time I went, she had a new picture for me that she had colored. And so I would pull up and I would hear her running. And so she rarely was in her hospital bed. When she would see me coming, she would run and jump in her bed. So when I would walk in, she was like, and she was breathing hard.
She was trying to fool you.
Yeah. And I was like, well, what have you been doing? And she's like, oh, nothing. And her daughter would come out and she would say, she just jumped in that bed because she thinks hospice patients are supposed to look a certain way, and y'all are going to kick her off if she, isn't in the bed. And she was so funny. I mean, she did everything for herself. She got up and took care of herself, cooked her meals. I mean, she's running off and jumping in her bed. And then she passed away through the night. So, she never had that decline.
Right. So that you guys have kind of discussed this a little bit, but I wanted to go ahead and ask the question, what is the best part of hospice nursing for you guys?
For me, it's very fulfilling. When you walk into a home and these families are grieving, and I mean, some of them are even angry.
Right.
And you're able to go in and soothe the atmosphere. You're able to take a patient that is having some distressing symptoms and help alleviate those and make med changes to where they're comfortable. And the family is so thankful for that. And they're just, what would I do without you? That is just a feeling of, you can't even explain it. It's just your heart is full. So, for me, you don't get that anywhere else, where you just feel appreciated and just my cup runs over
with joy. I would say my favorite part is really educating the family and advocating for the patient, because so I won't lie, when I first heard about hospice and things, I had that mindset oh my God, hospice, this person is going to die quick. And a lot of families think like that because of the lack of education. And I love being able to go in and educate the family. Hey, we're not here to speed anything up. Right. We are not medically capable of speeding anything up. This is just to create comfort and make the patient's last days. I feel like the quality of life should be better than the quantity. So we're not going to try to extend anything, but we want them to be comfortable.
Right. You're not doing anything with the time period. You're just there to help,
Exactly.
Right. And like you guys, like you had both said, with the hardest part and the best part, it is, the difference between, the sorrow you feel, but it also causes as much joy as it causes sorrow. Yeah. Yes. So, I mean, it is a kind of a roller coaster of emotions, but that is kind of, it sounds like, both of you have said it's so fulfilling to get that full range.
And making that difference. And the team, they make the biggest difference. Like
it's like a community, a family, within your fellow nurses, with the families, the patient themselves.
Yes.
Well, it's so important. I'm so glad you guys came on to kind of talk about this. Not a lot of people know, the ins and outs of hospice nursing, even the hospice process, like you said. It's all about educating and kind of busting those myths. And I just want to say thank you guys for coming in and sharing what it's like to be a hospice nurse.
Thank you for having us.
Thank you guys. Thank you for listening to We Talk Health. This podcast is not intended to replace any medical advice. Nothing said in this podcast is intended to supersede or supplement the direction of your medical caretakers. If you have any questions or would like to request a topic, you can reach out to us at wetalkhealthpodcast@gmail.com.